Good morning. So I'm going to talk about a very important topic, that is taking the patient off the ventilator. So the objectives for my talk are to learn how to assess the readiness for weaning, to understand various methods of weaning, the peri-extubation care, and the approach to patient with difficult weaning. So what's weaning? Weaning is a progressive, gradual reduction of ventilatory support leading up to extubation. That is weaning from ventilator. The advantage of weaning is, of course, there are lesser chances of ventilator-associated pneumonia, decreased ventilator-associated lung injury, decreased ICU length stay, decreased chances of venous thromboembolism and GIT bleed, because mechanical ventilator is a very important risk factor for GI bleed. Weaning has a two component. One is the liberation from the ventilator or the discontinuation from the ventilator, and the second is the extubation. And the liberation from the ventilator is a two-step strategy. Which involves that you have to see whether patient is ready for weaning, and the other is the actual weaning process. So, whenever you put on a patient on a ventilator, you should be very aggressive to ventilate a patient, but you should be even more aggressive to wean a patient. So, every day after you have put a patient on a ventilator, you should assess whether patient is ready for weaning from the ventilator. And during readiness to wean, what is the readiness criteria? It could be a objective clinical criteria and the physiological tests, which are called predictors. The clinical criteria is the first and the most important, is the underlying condition for which you ventilated has been taken care of. Like if there was a pus in the abdomen and you've not drained, patient is not ready to be weaned off. Pneumonia, you've not treated with antibiotics adequately. So the primary reason for which you had ventilated has been taken care of, has resolved, or is resolved, you feel that he can now do without ventilator. That's the most important first thing when you consider to wean a patient from the ventilator. The second is patient is hemodynamically stable and or is in a minimal vasopressor like 5-7 mics of non-adrenaline per minute. The third is the oxygen is adequate, that is PF ratio is more than 150, PEEP is less than 5 and FiO2 is less than 0.4. Now it is the time that we all should start talking in terms of PF ratio rather than PaO2. In your rounds everywhere, you should talk what is the PF ratio, because that's more important than what is the PaO2. Then the third is that patient is able to initiate spontaneous breathing efforts, that he is able to trigger the ventilator and you know that he is spontaneously breathing. Then he could be afebrile or a lower temperature. He should not be having a very high grade of temperature, because there are more chances of weaning, failing if you try to wean that patient from the ventilator. He's got a stable metabolic status. That means even if it is a metabolic acidosis, his pH should be less than 7.25, more than 7.25. Because if it is less than 7.25, he would be hyperventilating. And then the chances of getting tired and failing weaning will be very high. He should have adequate hemoglobin, more than 8, although you know that restrictive hemoglobin, restrictive blood strategy has been shown to be better than giving too much of blood to an individual, but it is one of the retrospective analysis that shown that if you keep above 8, it is associated with a better weaning. Patient should have adequate mentation. His GCS should be more than 8 when you think of weaning, and he should be off sedation. So these are the very important, and he should have an optimized fluid balance. When a patient comes with sepsis, you give too much of fluid, he is swollen and his cumulative fluid balance is very high. So you should, if it is too much positive, then the chances of failing are very high. You need to make that patient negative or de-escalate, which is now in the 4 phases of fluid resuscitation. You should de-escalate because it will help you into weaning that patient from the ventilator. And positive fluid balance, the moment you take off the ventilator, the venous return will increase, more blood in the lung, patient may get a pulmonary edema, he will fail the extubation. Now the physiological predictors. There are numerous physiological and you have to remember them for exams. In practical, many of you who are working, very rarely we use them in day-to-day practice. And they have not shown to, but it is good to know what are these physiological predictors. If you want to assess the ventilation requirement should be less than 10 liters. Normally we all are breathing at 5 to 6 liters. If patient is breathing, that means we are breathing at 10 to 12 breaths per minute. Even if he's breathing 25, that's okay. So if he's breathing at let's say 30 and 40, his ventilatory requirement is quite high. Like you are seeing that you are giving 18 breaths per minute, but patient is taking 30, 35. He is not ready. So his ventilatory requirement should be less than 10 liters. So that will show that his ventilation requirement is not very high and he can be extubated. Then to assess the strength, maximum inspiratory strength, when patient takes a breath against a closed airway, if it is less than -30, maximum inspiratory pressure, that is an indicative of a weaning success. But if it is more than -20, then chances of failure are high. Then the tidal volume should be 5 ml per kg. The vital capacity should be double the tidal volume, that is 10 ml per kg. And to know the endurance of a person without ventilator, although I have written many of them, the most important out of this is the F/VT, which is called the rapid shallow breathing index. If it is less than 105, it is indicative of a weaning success. Then the static compliance. Static compliance normal is about 60 to 100. If it is less than 33, it is an indicator that patient endurance is very bad. Similarly, occlusion pressure. Occlusion pressure is when patient makes an effort against a closed airway, the first 0.1 second, the pressure should be less than 2. If values are greater than 4 to 6, it's an indicative that there will be weaning failure. These two are very important, the occlusion pressure and the static compliance. 33 ml per kg per centimeter of water, and the occlusion pressure 4 to 6 is an indicator of weaning failure. Then, because weaning is dependent on a lot of things, so they came up with what is called the integrated indices, which is the crop index, core index, weaning index, and integrated weaning index. They are very complicated formulas, but none have been confirmed to have a high level of accuracy that was initially reported with all these. So out of these, if you see, of course the minute ventilation you can see, maximum inspiratory pressure you can see, the vital capacity is not difficult to see. The rapid shallow breathing index, which I was saying, is the one which has been found to be easy to do and has been found to be good predictor of a weaning success. If it is more than 105, that has a better specificity than F/VT less than 100, because they have seen even people who had passed RSBI, they still fail because there are other factors also come into play. But a person whose F/VT is more than 105, there's sure chances of failure. So this is what you do is that you put a patient on a T-piece and attach it to a spirometer. This is the best way. The other is that you put a pressure support of 0, CPAP of 0, and flow trigger also you take off. And then you see the F/VT, and that's how you can see a patient on ventilator. And the best way is to see on a T-piece connected with a spirometer. We used to do it, it was available, but nobody practices nowadays, and that's why that spirometer is, don't think is available in most of the ICUs. Now, once you've done a daily screen and you feel the primary reason for which you ventilated is corrected, clinically this patient looks fine, then you prepare for weaning. You must talk to the patient, even if he's with a tube. Explain the procedure, calm him down, record baseline parameters, and I think very important that time again to see the fluid balance, because if it's too much positive, the chances of failure would be very high. Keep a peaceful environment and talk to him and make him comfortable, because he's going to do a procedure. The chances of success would be high if he knows what you're going to do to him. He should be on no sedation. Whenever possible, position the patient upright in the bed, thoroughly suction the endotracheal tube and ensure patency. And then what are the methods? Once you've done this, you explain, then what are the methods of weaning? One is a spontaneous breathing trial, the other is a progressive decrease in the level of pressure support, and the other is progressive decreases in the ventilator assisted breath, that is the intermittent mandatory ventilation. Some of this has not been practiced. First two are the one which are practiced, and out of this, spontaneous breathing trial is the one which is more practiced. What is spontaneous breathing trial? The spontaneous breathing trial means that you allow the patient to breathe spontaneously, either on a T-piece or with a minimal ventilatory support, which could be a low level of pressure support. It could be automatic tube compensation or CPAP for 30 to 120 minutes. That is how you define a spontaneous breathing trial. So these are the 4 ways of giving a spontaneous breathing trial: T-piece, low level of pressure support, CPAP, and automatic tube compensation. What kind of method you will choose, it will depend on the local availability and the preference of the clinician in charge of that case. Duration 30 to 120 minutes. They have seen 30 minutes is as good as 120 minutes, so you could just try only for 30 minutes. When you do this, you should observe patient comfort, dyspnea, vitals, respiratory, and SBT should be terminated if it fails. What is the failure? Failure is patient is getting agitated, his mental status is depressed, he's perspiring, diaphoretic, cyanotic, his facial sign of distress, dyspnea, increase the accessory muscles. You know that if you worked in ICU, you know that patient should be put back on a ventilator or put back on the support which he was already. And if you want to see objectively, when a PaO2 less than 50 on FiO2 of 0.5 or saturation is falling below 90, PaCO2 is more than 50 or rise of 8 millimeter, pH has fallen below 7.32 or it has fallen 0.07, RSB is more than 105, respiratory rate is more than 35, heart rate is more than 140, or there is a 20% increase. Similarly, blood pressure more than 180 or 20% increase or decrease. Diastolic blood pressure less than 90, cardiac arrhythmias, you failed. If all these do not occur, then you have passed the SBT. Patient is comfortable, oxygenation is alright, carbon dioxide is not rising, pH is not falling, then you know that you are going to succeed with this patient. Ventilation after SBT failure, once you failed the spontaneous breathing, you give him a non-fatiguing, comfortable form of it. Don't put him on a low level of pressure support. Give him a full, I always prefer a sys control or a high level of pressure support once you fail the spontaneous breathing trial. Then you must find out what is the cause of failed SBT. Once you know that the reason for which the SBT had failed, corrected, then you can again perform the SBT. And never perform an SBT earlier than 24 hours, because once the muscles are tired, it takes 24 hours for diaphragm to recover. In the morning it failed, don't try in the afternoon, you may again fail. So whatever the reason, correct that, apply your mind, and then try maybe the next day. And when you try for the next time, preferably try for 120 minutes. The other method is weaning by progressive decrease in the level of pressure support. This is the other method. In addition to the spontaneous breathing trial, you could try the progressive decrease. Like if the pressure support is 14 today, you make it 10 or 12 next day. And if he's breathing all right, the next day or in the evening, you can decrease it further. Intermittent mandatory ventilation, I said, is not used for weaning. So these are the two important methods: spontaneous breathing trial and a progressive decrease in the pressure support, the most common and the most effective method of weaning. There are newer methods which include the computer-driven automated PSV weaning, which is you feed the data and what are your requirements, and then the ventilator will automatically decrease the support, and once it reaches a value, then you start thinking of extubation. When you extubate a patient and put on an NIV, that's not, the patient is still not weaned, and you call this as a weaning in progress when you had to put a non-invasive ventilation after extubation, except for patient of COPD where you always give non-invasive ventilation. Then after you've done this, wean the patient of the ventilator, the next important step is the extubation. Criteria that define the success of a spontaneous breathing trial, they do not necessarily reflect the success of extubation. About 10% of patients who had passed weaning will fail extubation. SBT or spontaneous breathing trial is useful in assessing the load and capacity, whether patient has capacity to bear the load of his breathing. But when you extubate, you have to see the upper airway patency, bulbar function, sputed load, and the cuff effectiveness. Successful extubation is when you do not require the intubation for 48 hours. Patients who receive post-extubation NIV are classified as weaning in progress. So what are the prerequisites for extubation? You should see the patient has an adequate cuff reflex. You can ask him to cough, put a suction catheter. If he's coughing very nicely, then you are done with it. He's able to protect airway. He's not drowsy. His GCS is more than 8. And you know that he doesn't have bulbar dysfunction. It's sometimes very difficult in a neurological patient to assess because the reflexes also decrease. He's following simple command. He's raising his hands. He's raising his legs. You know that there is not significant critical illness neuropathy. Ask him to push. Ask him to pull. These 4 or 5 tests can tell you that whether critical illness neuropathy is there. And secretion should not be copious. No radiological or surgical procedure is being planned in the evening and you are extubating where they again re-intubate. Then in our country, you should try, if your staff is always less at night, so do not plan right at the end of the day when you could do early in the morning. Then there are certain tests also suggested. What is it? Cuff leak test. Cuff leak test is you put a patient on assist volume control and see the inspiratory tidal volume and expiratory tidal volume. If you deflate the cuff, there should be some leakage of air, so expiratory tidal volume should be less. If you deflate and you can listen the sound coming, that means there is enough space around the vocal cord and not edema, so patient will not have a stridor. The other thing is to see the difference of 110 ml between inspired and expired. If that is there, that means the patient has enough space and there are no chances of having a cuff stridor or obstruction after the extubation. Then once you've done all this, then you pre-extubation, you should do aggressive suction clearance. You can put a nasal trumpet if there are a lot of secretion, and it is ideally advised to inspect the airways prior to extubation. Post-extubation, you should be ready before extubation with the mask. Don't ask the sister to run for it, and everything will be there once you extubate, and either put on a nasal prong or mask, and if he requires NIV, you can put him on NIV. Then you observe the patient for extubation failure. He should have a respiratory rate 25 for 2 hours. Heart rate should not be more than 140, and there are no signs of respiratory muscle fatigue. The SpO2 should be more than 90. If it is less than 90, or PO2 is falling on FiO2 or more than 50, or patient is developing hypercapnia and pH is falling, probably this patient is failing extubation. Early extubation failure occurs because of loss of airway patency and upper airway edema. And in neuromuscular patient, because of the bulbar dysfunction and ineffective cuff. These are the causes of early extubation failure. And late extubation failure occurs when there is a capacity load imbalance, impaired bulbar function, he is aspirated, he's got ineffective cuff, typically neuromuscular and chest wall diseases, and non-respiratory issue, like patient has a left ventricle dysfunction, you extubated and probably of some extra fluid or failure, he failed. So these are the 4 things when the late extubation failure, and the early extubation is mainly because of the airways. You could try non-invasive ventilation. It's most effective in COPD, post-operative patient after lung resection or upper abdominal surgery, and obstructive sleep apnea and the obesity hypoventilation. These are the 3 group of patients where you must put them, not necessarily this, but COPD and decompensated obstructive sleep apnea and the obesity hypoventilation syndrome. You should put them on non-invasive ventilation because they would require these anyway, so it is better to put them and give them some support during this period. Now, coming on to the next 10 minutes, I will talk about the difficult weaning. Simple weaning is that you gave first SBT and patient succeeded in extubation. This is the simple weaning. Anything above this is a difficult weaning. That means a person who requires at least 3 attempts of SBT or requires 7 days to wean a patient from ventilator after you fail the simple weaning, that's called the difficult weaning. Okay, simple weaning is the first SBT you succeed. Difficult weaning is who requires 3 SBTs or 7 days from the first SBT to achieve successful weaning is called difficult, and anything more than this, more than 3 weaning attempts and more than 7 days is called the prolonged weaning. So these are the words you should use when you are in the rounds. So you should always think what is the reason for the weaning failure. You know, it is, as I said, the load is more, the capacity is less. That's the reason you fail. The load is more, there is elastic load is more, there is increased PEEP, pneumonia, pulmonary edema, pleural effusion, or there is increased resistive load, there is so much of bronchoconstriction, increased ventilatory demand, he is metabolic acidotic, he's got anxiety, and these are the causes of increased load. And he's got a decreased ventilatory drive, he's still sedated, he's alkalotic, his neuromuscular capacity is less. So these are the reasons that why the weaning fails. So we'll deal quickly one by one. You know, when you have a difficult weaning, you sit by the side. Just see the file right from the beginning. Why did I fail? Because if you do this, most of the time you will identify 2-3 causes why you failed. Am I missing something which requires attention? Has the first thing is, has the primary condition resolved? Has the pneumonia resolved, or was I quick? Was I early? Or there is primary condition is still not being taken care of. The fracture has not been fixed. You know, patient of ARDS, maybe something which requires attention. Then let's deal the load, the capacity. So inadequate respiratory drive, nutritional deficiency. Are you feeding him well? So that's the thing you should, and avoid overfeeding but give him good nutrition and good glycemic control. Then has the effect of sedative still there? And when you are thinking of weaning, you should avoid continuous infusion, give intermittent short acting like propofol when you are thinking of weaning in such a patient. You know, whenever you over-sedate, you will not be able to mobilize a patient. And if you don't mobilize, the only preventing factor for critical illness neuropathy is mobility. So if you make these patients mobile, you will avoid the critical illness neuropathy. You should have some or the other patients sitting like this. If you go to my ICU, 1 or 2 patients always during daytime would be sitting, whether ventilator or off ventilator. You must mobilize these patients. Because once they mobilize, when you're thinking of weaning, it becomes very, very easy process. When you can mobilize, remember move. Move means myocardial stability. There is no arrhythmia, is myocardial stable. Good oxygenation, FiO2 less than 0.5. He's off vasopressor or low dose. 5 to 10 mics is not a contraindication. And he can be engaged to respond. If these four things are present, please make them sit. Because don't think that he's on a vasopressor, he cannot be mobilized. He should be on a very low dose, it's okay. Because this will help you to mobilize or wean off patient quickly from the ventilator. Then, it's very common that patients who are in ICU on sedatives, renal failure and others, some amount of residual sedation remains. You don't have a very obvious reason for the sedation, but patient is drowsy. Give him methylphenidate or modafinil, which is available very easily. So these patients will help you to wean that patient off the ventilator. Then the very important is the central nervous system abnormality, delirium. Sepsis, multi-organ failure, ICU, old age, metabolic alkalosis, all these are risk factors for delirium. And I will not go into details of how to diagnose delirium. It is a hypoactive and a hyperactive. And hypoactive is very common. Sometimes patient is drowsy, you don't know what is the reason. Everything is fine, but this person is drowsy. It could be a hypoactive delirium. And you could give a haloperidol, quetiapine, risperidone, olanzapine. We prefer quetiapine. Patient is drowsy, you give him quetiapine, you've ruled out everything, you'll find the next day the patient is conscious. Because it was delirium and it was not the drowsiness because of any other reason. Then sleep deprivation. Patients don't sleep, they get tired. If you ask him in 24 hours, he had a 4 hours, 2 hours, 2 hours sleep. We normally in all these patients give zolpidem. Give a zolpidem because midazolam doesn't give a good sleep. Give 5 milligram midazolam, the zolpidem to these patients, and you will find the next day the patient is more active and energetic to be weaned off from the ventilator. And hypothyroidism, of course, if it is there, you must take care of. Then the other is inability of the lung to carry out exchange effectively. So unresolving pneumonia, take care of this. Unresolved pulmonary edema or fluid overload is also very common condition. Re-establish the fluid balance. Consider albumin and furosemide. Treat pulmonary edema aggressively. Keep a patient negative when you're weaning off. You can give him fluid once he's weaned off. Avoid fluid in renal failure. And do dialysis if you feel this is the reason and he's not producing enough urine, creatinine is high, then you do a 1 or 2 dialysis and you will find you are able to wean out the patient. In a left ventricular dysfunction, do a NT-proBNP, and if you find it is high, make the patient negative, you'll be able to. Then undiagnosed pulmonary embolism, also always keep in mind when patient is very dyspneic and you're not able to wean out. If there is too much of pleural effusion, too much of ascites, you can do a tap at that time, and there are papers where they have able to wean off these patients of difficult when they did a bilateral chest tubes, but at least do a tapping in these individuals. Then all these electrolyte abnormalities should be thought of and corrected. Similarly, hypothyroidism and anemia, if it is too low, at least bring it to 7 to 8. Respiratory muscle weakness, steroids, myopathy, you need to think of reduce the doses of steroids. Hypothyroidism comes everywhere. Sepsis is still not resolved. These are refractory hypoxemia and hypercapnia. All these things will lead to respiratory muscle weakness and which you need to take care of in these patients. If a patient has a patient ventilatory asynchrony, that you should, when you are ventilating, you think it is not important. If there are too much ineffective triggering, it delays weaning. So you should see when you are ventilating that patient is synchronous with the ventilator, which will also help to wean this patient off the ventilator. Critical illness neuropathy is best avoided. Once it is there, then you have to give time to the patient. If there are secretions, then you need to do aggressive suctioning in these individuals to try weaning. If there is anxiety, these are all the reasons that patient becomes psychologically dependent also many a times. So you have to allay anxiety by talking to them. And sometimes you can give them low dose benzodiazepine also if you have this kind of problem. Once you deal with it, you've looked at all the factors which could be responsible, then you select that now I have taken care of, then how to wean off. Although the method is not very different, you could use any of the modes to give the ventilation to these individuals. But there are two basic weaning protocols: progressive reduction of ventilatory support, whatever you're giving. The most common still we try is the pressure support, as I said, that progressively decrease the level of pressure support every day. 14 first day, 12 next day, 10 next day, 8 next day. When it reaches 8, then you know this patient. Don't be in a hurry. The problem of difficult weaning is you are in a hurry. The primary consultant is in a nikalo. That's how all these patients are difficult weaning. Who's been there on 15 days just needs time. Just give him time and you will be able to wean off. Or progressive longer period of spontaneous breathing trial. Put him on a T-piece, 2 hours, put him on next day maybe 4-5 hours, third day 12 hours, and then you are next day maybe 24 hours, and then you can consider extubation in that individual. Non-invasive ventilation could be tried even in cases of weaning failure when you have a difficulty. Then prolonged weaning, you must tracheostomize these patients because it does help. Although they have not seen that difference in the outcome, but tracheostomy does help in these patients to wean that patient off the ventilator. So if you still fail, then you have to again treat it. Okay, then you will be able to wean your patient off the ventilator. So just to summarize, that weaning is a gradual reduction of pressure, the gradual reduction of the ventilatory support and take the patient off the ventilator. It has two components. One is the discontinuation from the ventilator and second is the extubation. And the most important for discontinuation is to daily see whether patient fits into the clinical criteria which I enumerated and few of the physiological indicators, but most of the time it is the clinical indicators which tell you the patient is ready for the weaning from the ventilator. And after you've done this, you do a spontaneous breathing trial. If you succeed, then you see whether patient can be extubated. You see all the criteria that patient fulfills the criteria for extubation, then you extubate the patient. If you fail, then you must spend time and look for all the causes which can cause the weaning failure, and if you fix all those causes, then you start doing the weaning, and most of the time you will be successful. Thank you very much.